Hello everyone, thanks for joining. Today's session we're going to be focusing on optic neuritis. We're going to go through the classification, how to sort of think about it, and then talking about your sort of typical demyelinating course versus your atypical causes of optic neuritis. When it comes to the classification, there are sort of two main ways to think about optic neuritis. You can either think about anatomically where the inflammation is happening. So is it retrobulbar, where your disc is usually normal in appearance? Do you have a papillitis with some optic disc swelling? Um, or is there actually a neuroretinitis as well with some macular inflammation? And they usually all present kind of different rates and also to different causes. So when you're thinking of your causes in terms of the classification, you're looking at things like demyelinating diseases being your primary cause, and then you've got other precipitating factors as well. So either it's a kind of post-infectious optic neuritis, an infectious optic neuritis, or a completely non-infectious optic neuritis. And when thinking about demyelinating disease, which will probably be the most common cause of optic neuritis you come across, that will typically present with a retrobulbar optic neuritis. Papillitis tends to be the presenting feature in sort of younger children, but neuroretinitis is quite an uncommon presentation of demyelinating optic neuritis, but it's a bit more common when you're looking at more of the infectious causes of optic neuritis. So, jumping in with demyelinating, the sort of conditions that you're wanting to think about are things like multiple sclerosis. It could be an isolated disease. So, it's just an optic neuritis that you're looking at. And then you've also got your sort of neuromyelitis, as sort of spectrum disorders and your sort of MOG antibody. And there's a lot of overlap between those diseases, and we'll talk about that in a moment. And your sort of main features, if you're thinking about what your demyelinating optic neuritis looks like, is that you'll usually have a sort of subacute monocular visual impairment. Usually, in 90% of cases, it's presenting with some sort of pain, and that's usually exacerbated with eye movements. You'll obviously have some of defects to your optic nerve. So you might have an RAPD, you may have visual field defects, problems with color vision, problems with their acuity. And the majority of these patients are going to sort of self-resolve, and they will usually recover to vision better than 6/9. So visually, from a demyelinating optic neuritis point of view, the prognosis does tend to be quite good. And when you're thinking about what typical optic neuritis is, the reason it's useful to have an understanding of what typical optic neuritis is because when it's atypical, your red flags need to be kind of flagging up in terms of what else could be going on. Whereas typical optic neuritis is probably a demyelinating picture. So you're looking at someone who's, 20 to 50 years old, it's unilateral, it tends to be quite acute in presentation, so something over a few days. And then it tends to recover by itself. Of course, otherwise you might want to give some IV steroids for whatever reason, but these do tend to self-resolve. 90% of them, like I said, present with pain, and then you'll have features of these optic neuritis. And importantly, you usually have a more moderate visual loss. It doesn't tend to be a severe visual loss. So you're looking at vision sort of, your 612 to 636 sort of mark. They don't tend to drop to your sort of counting fingers, hand movements vision. That tends to be a very different kind of cause of optic neuritis, or you're even potentially looking at an anterior ischemic optic neuropathy. So bear that in mind, in that it's not necessarily a hard and fast rule, but their vision doesn't tend to be that bad. So do sort of think about other causes if you're looking at someone presenting with really quite poor vision. So when you come to think about what multiple sclerosis sort of in the context of optic neuritis, when someone presents with an optic neuritis, they're over 15 years, they have about a 50% risk of developing MS, and that will vary depending on whether or not you have lesions on an MRI, which is why an MRI presentation is really helpful because you know how to prognostically sort of categorize your patient. So if they have absolutely no lesions on an MRI when first presenting with an optic neuritis, their 15-year risk is actually can be as low as 25%. But if there are lesions, then it's up to 70% or even potentially more. So that initial MRI is really important. There are other associations, so things like HLA, DR15, DQ6, these are all associated with MS. And remember that in MS, actually, a good proportion of them will present with the eye symptoms. And that's typically because if you think about what else they'll present with, is things like pins and needles, numbness, a bit of weakness to a limb, which again, because it's a relapsing, remitting, usual course, then it will self-resolve. And those patients don't typically present, whereas vision tends to be a bit more concerning. It's a bit more obvious as a problem. They can't just put it down to something like fatigue or pins and needles. So 30% of patients will present with optic neuritis as the primary presenting feature of an MS diagnosis. But those with an established diagnosis, about half of them will eventually present with an episode of optic neuritis. And when you're managing disease, usually there's a question as to whether or not you give steroids in the acute setting. Now, importantly, it does sort of delay MS in the very acute stages, but what the treatment trials have shown us is that over 3 to 5 years, there's absolutely no difference in terms of whether or not you give IV steroids. Now, the reason you would give steroids is, for example, the how profound the visual loss is, or for those, for example, whose other eye is poor or they only have one eye and the optic neuritis is happening in the better eye, and you might want to kind of speed up visual recovery. You may want to consider giving some steroids. And importantly, what the trials have shown is that giving oral steroids alone can actually sometimes make the optic neuritis worse. So usually the treatment is IV methylpred, a gram, every day for 3 days, and then you drop them to oral pred over the rest of the 2 weeks. Then you want to think about some long-term treatment. So with MS, you're thinking about things like interferon beta. There's all sorts of monoclonal antibodies that can be used, and they all come with their own sort of risk profiles. And there's definitely a sort of MDT approach to these patients between the ophthalmologist, the neurologist, and all sorts of sort of occupational therapists as well, depending on how bad the systemic disease is. But there's lots of different things to consider when managing it. When you want to think about your sort of neuromyelitis optica disease in terms of kind of differentiating it between MS and this, usually you've got a patient who's presented with optic neuritis, maybe a myelitis, and they also have like a transverse myelitis of the spine. So it tends to be quite sort of it doesn't affect the brain in the way that MS does. It's more sort of spinal, and then your optic nerve. And the way to sort of think about these diseases is, like I said, there's a lot of overlap. People will sort of put anti-MOG within the neuromyelitis optica spectrum. But essentially, neuromyelitis optica is usually associated with aquaporin 4. And your treatment and your sort of diagnostic criteria is if you're aquaporin 4 positive, you then only need one of those three presenting features in terms of optic neuritis, acute myelitis, or a longitudinally extensive transverse myelitis, or LETM for short. If you're aquaporin 4 negative, you need to have optic neuritis plus LETM for the diagnosis. You're going to treat these patients acutely again with steroids, but then the reason it's important to differentiate between this disease versus MS is actually a lot of the MS treatments can actually aggravate NMOD. So definitely consider this as a potential diagnosis if your MRI is not showing any cerebral lesions and only spinal lesions. If you are aquaporin 4 negative with the above features, it's useful to then actually send off for anti-MOG, because anti-MOG is a slightly different kind of disease. It's usually associated with a better prognosis. Sometimes anti-MOG disease is a single episode. So sending your anti-MOG and your aquaporin 4 together is about trying to figure out where on that spectrum they lie if you're thinking that they are neuromyelitis optica spectrum. So the thing to bear in mind here is that the main differences between this and your MS is that your optic neuritis is usually associated with spinal lesions, no brain lesions. So it usually spares the brain. And typically you've got like a female preponderance. They present at similar ages. But the main thing to take away from this is that they have slightly different features, and a slightly different sort of prognosis. And the treatment for neuromyelitis optica spectrum disorders is usually with immunosuppression, things like mycophenolate, for example, azathioprine. You're not going to be using lots of monoclonals. There are some monoclonals that are used, like rituximab, but you want to try and avoid MS monoclonals that we mentioned because they can actually aggravate the disease. And NMOD is typically carries a pretty poor prognosis if it's untreated, especially because of those spinal lesions. But if it's treated, then that 5 year survival tends to be much better. So you're thinking about things like is it a relapsing disease? Is it monophasic? In terms of discussing whether or not the prognosis of the patient is good or bad. But generally, aquaporin 4 negative, anti-MOG positive disease is usually a better prognosis. So moving on to your sort of para-infectious. So this is basically somebody who presents, a few weeks after a viral illness, typically. And, you're looking at your most common viral causes of something like, a chicken pox, measles, mumps, rubella, whooping cough in children. These are people who are going to then present maybe 1 to 3 weeks later with this sort of bilateral optic neuritis. And actually, they can have quite profound vision loss in the episode, but importantly, they tend to actually they tend to recover very well, sorry. And usually, you're actually not having to treat these at all. But sometimes in children, or if they have very severe bilateral visual loss, or if they only have one eye, again, you may consider giving them some IV steroids just to speed up the recovery. But generally, these patients do tend to self-recover really well. So when you're thinking about infectious causes of optic neuritis, these typically present with a neuroretinitis, and they also typically present with a uveitis. So if you go to the sort of infectious uveitis talk that I've given, you'll come across, the Bartonella, your syphilis, your Lyme disease, and these are essentially patients that are presenting with an optic neuritis and macular inflammation, and that's where you get this typical picture of a macular star. Now, I wanted to talk about neuroretinitis in that it's like I said, it's a combination of your optic neuritis with a macular inflammation, and most typically you get lots of infectious causes as the reason that this happens. But importantly, it's very good to remember that neuroretinitis can be caused by malignant hypertension, which can be, life-threatening in the acute setting. So it's always important when you actually comes to investigating neuroretinitis, you're doing a blood pressure. You're also going to do an OCT, an FFA. You're going to send off some bloods, maybe some serology to look for infective causes. But do remember to check the patient's blood pressure because that could be what you're looking at. And neuroretinitis itself tends to self-resolve. But you essentially have to treat the underlying cause. So if it's an infectious cause, treat the infection. If it's hypertension, treat the malignant hypertension. But the neuroretinitis itself tends to settle down and they usually have quite good visual recovery. And then finally, when looking at your non-infectious causes, mainly you're looking at sarcoid. You may have some sort of lumpy appearances to the optic nerve head, usually because of a sort of sarcoid granuloma. And if you treat the sarcoid, usually this is treated. And then autoimmune conditions can really take lots of different forms in the eye. And they can also present with an anterior ischemic optic neuropathy. And we'll have a session specifically looking at ischemic optic neuropathy and the differences between your arteritic and your non-arteritic versus your posterior ischemic optic neuropathy. So that brings us to the end. Essentially, we've just, talked about the classification of optic neuritis, how you sort of manage it, and a lot of it will depend on what you think is driving the optic neuritis. And the most common thing you're going to come across is demyelinating disease, which is typically MS, but you also need to consider other causes of demyelination as well. So thank you very much for joining. Again, please do remember to fill out the feedback. There's a link in the description if you're watching this online. Thank you very much for joining, and we'll see you at the next one.